Good morning.
Good morning.
Good morning?
Good morning.
Good. I'm glad to see that there's energy in the room after Princess Dinamira's excellent presentation this morning. It's an immense privilege and a pleasure to be here in Hong Kong and to contribute to the symposium, and huge thanks to the organizers. Now, cancer is very important. In fact, so important that in the case of Hong Kong, it's number one in terms of number of deaths, the highest death rate. Now, one must take a step back and say, why is that? Hong Kong has been very successful as a health system. It's one of the success stories, actually. It has, in terms of expenditure, spends around 6% of GDP on health system. Yet, death rates for cancer are very, very high. Now, the reason for that is countries like Hong Kong and many others in Southeast Asia are, in effect, a victim of their own success. Because the life expectancy in these countries have increased very, very rapidly. So if you look at the total gain in life expectancy between 1950 to 55 to 2010 to 2015, in Asia, almost 30 years were added to life expectancy. And as we heard, as we get older and as deaths from other conditions decline, number of cancer incidence increases, and of course people will have to die from something. So death rates from cancer are very high. So what is important is not that life expectancy is increasing, but the speed at which this increase has happened. And I'll come back to that. So if we look at the death rates by leading cause, these are not age standardized rates. Cancer is number one and increasing. Even age standardized death rates, although they're declining, largely driven by the declines in lung cancer and nasopharyngeal cancer in the case of Hong Kong, cancer is still number one. But even though cancer is number one in terms of death rates and in many other countries, the data in relation to cancer are actually quite poor, generally in the world, also in this region. It's very difficult to know actually what's happening. I was in Latin America recently and tried to understand what is the real burden of cancer, how are patients managed, what is the economic cost. It was impossible to ascertain what was happening. So we have a problem. We have a number one killer, which we should all be concerned about, yet the data on this number one killer is very limited. So there's an asymmetry between what needs to be done and the burden of disease. Now, if we look at survival from cancer, this is from Concord 3, and benchmark what Hong Kong is achieving in relation to others, we see areas for potential improvement. So this is quite a busy slide, but we're concerned with there's Hong Kong, there's China. This is 5-year net survival for adults, 15 to 99 years. So we have colon cancer. So Hong Kong is here. It's actually below what many other countries in the region are achieving, and far below what countries in Europe are achieving. For breast, Hong Kong is doing fairly well, but it's still below its potential, below what is being achieved by other countries in the region, and below what's being achieved by the vast majority of European countries. For acute lymphoblastic leukemia in children, we don't have data for Hong Kong, even though Hong Kong is a fairly good registry. But if we use China as a proxy, because for colon and breast cancer, the 5-year net survival levels are quite similar, China is not doing terribly well compared to other countries in the region that have reliable registries, and far worse than what other European countries are achieving. So there are challenges, there are also opportunities, because it tells us that Hong Kong can improve. Now, we often talk about the burden in terms of health, but we should also be concerned about the burden in terms of the economic cost of diseases, especially cancer, that is number one in the case of Hong Kong. So this is a study done by my colleague, Sir David Bloom, who looked at economic burden of cancer globally, and using three different approaches. Using the cost of illness approach in 2010, he estimated the cost was 290 billion, projected to increase to 460 billion by 2030. Using value of lost output, which also takes into account loss of productivity, the numbers are quite large, $8.3 trillion in the period 2011 to 2030, of which 5.4 trillion was in high-income countries. But using a value statistical life, in 2010, the loss was economic loss was $2.5 trillion, projected to increase to almost $5 trillion in 2030 per year. So the economic cost is very large, beyond the human cost of cancer. So why are we not responding effectively? Now, it's all about the speed of change. This is what I call the innovation challenge. The speed of change in terms of the demographic transition, increase in longevity, and the epidemiological transition that has followed, that has brought cancer to number one, has happened very quickly in many of the countries. Again, you're a victim of your success. But in health systems, changes happen very, very slowly. I wrote an op-ed for Financial Times, this is about 2 years ago, where I argued that it's time to transform healthcare delivery. And I pointed out that scientific developments, and we're living in a renaissance of scientific development, have spurred unprecedented delivery of innovations. So we have lots of new diagnostics, new medicines, new medical devices, but innovation and delivery, delivering these to patients, has faltered. Not much has happened in terms of, it takes such a long time to reform a health system. So if you look at delivery of innovations, we have new biomarkers, we have new diagnostics. This is a 1 penny stamp. I'm from Britain, although I live in the US. You can fit so much onto a tiny panel to do multiple tests. We have novel treatments such as immunotherapy that was mentioned. We have big data and analytics that enables us to transition to precision medicine. So lots are happening in relation to innovations. But in relation to innovation and delivery, not much is happening. So this is Hôtel Dieu in Paris. It was established in the 7th century. Has anyone been to Paris? Can you put your hands up? Has anyone visited Hôtel Dieu? It's still functioning as a hospital. 7th century, this is not a typo, 7th century. I did my postgraduate training at St. Bart's Hospital in London, established in the 12th century, 1123 to be exact. In one of those rooms, I would have a ward round, and my professor would very proudly say, this room goes back to the 12th century. And I still look at him and think, not much has changed since. So this is the challenge. The epidemiological transition has happened, but systems have not. Now, why is this important? Because in terms of health expenditure, the total cost of medicines, diagnostics, technologies are about 8 to 20% of total expenditure. This is where innovation is happening, and this is where we're constraining costs. But the health system component, which account for 80 to 90%, is where innovation is not happening. Not surprising that we're not getting the outcomes that we want. So we need to change our mindset. So that's the first challenge, the misalignment of innovations. The second innovation challenge is the policy misalignment. So on the one hand, we have push in terms of industrial policies that encourage innovation, entrepreneurship, new ventures, new technologies. On the other hand, we have health systems that constrain innovation and their adoption. And third, economic policies disregard health systems' innovation potential to contribute to the economy. So health is seen as an expenditure, as opposed to being an investment that can improve health and well-being of individuals, but also economy as a whole. And the third big innovation challenge is the institutional logic. And you'll recognize this gentleman. Would anyone care to say this gentleman is? Einstein, yes. Well, he said insanity is doing the same thing over and over again, but expecting different results. Okay? Now, 7th century, we still have the same structures. And in fact, the health systems are centered around these structures. The problem is that we cannot solve our problems with the same thinking we used when we created them. So the thinking we have is actually hospital-centric models that consume large amounts of health funds. So we need to completely take a step back and completely rethink what is appropriate to transform that 80 to 90% of the health system expenditure to improve efficiency, effectiveness, equity, and responsiveness. This is what needs to happen. Now that brings me to the cancer plans, because one can use the plan as the instrument for transformational change. But first we need to make an investment case. We need to change the narrative. And in a paper in The Lancet with my colleague Franco Cavalli, with several of my colleagues here who attended the World Oncology Forum, we suggested globally to address the cancer challenge, we should think about 5 areas. First is to develop a clear narrative about the challenges, the societal challenges of cancer, but also the opportunities. Secondly, to create an inclusive movement with leadership at all levels. Third, as part of this narrative, to create an investment case for sustainable financing. And this is very important, because the institutional logic is that health is an expenditure. It should be health is an investment to improve our well-being, but also contribute to economic development and sustainable development. Fourth, we call for investment in R&D and innovation for affordable solutions. And finally, expansion of cancer prevention and care, aligned with universal health coverage. I'll come back to that. So we need a plan, but first we need to make an investment case. We need to demonstrate to those who are going to fund cancer and health generally that resources can be allocated in an efficient manner to health and to cancer in general, because there are competing demands on the resources that are available. So investment case is important because it provides the opportunity to define the nature and the magnitude of the cancer challenge. It identifies priorities among the options that we have. It articulates cost-effective and equity-enhancing interventions to meet those priorities. Provides a time horizon for scaling interventions. It quantifies both the health and economic benefits of scaling interventions and return on investment, because one can estimate the cost, but also estimate the benefits in dollar terms or the local currency terms to look at what the return is. And finally, it can be used to make a compelling case for transparent and efficient allocation of new and additional resources. So this should be the starting point, making an investment case. But there are very few investment cases for cancer. We did one with my colleagues Mary Gospodarovich, David Jaffrey, and rising stars such as Daniel Rodan for radiotherapy. And we published the Lancet Oncology Commission, which actually was front page news in the BBC, but also was picked up by many of the other outlets around the world with the generous support of UICC. And in this commission, we're able to show very briefly that over time, and we used 2 different models in terms of efficiency model and nominal model, but essentially these are cost over time, and these are benefits using 2 different approaches, a human capital approach and a full income approach. And you can see over time, the benefits exceed costs. And you can see the benefits are actually very substantial over time. Now, this is important because radiotherapy was seen by many as being costly, complicated, complex, required long-term investments, required huge amounts of capacity, but we're able to demonstrate it can be done, and one can actually get very high returns on investment. In fact, we're able to demonstrate that in upper middle income countries, for every dollar invested, one would get a return of $2 using the human capital approach, and almost $6 using the full income approach. Now the bond yields nowadays are about 1 to 2%. Kerry, you're a finance expert. In fact, in some countries, the real returns are negative. So $6 for every dollar invested, that's a very good investment. That's for radiotherapy. If we were to extend this to other investments in cancer, we can demonstrate that this is a very compelling investment case. Once we've made that investment case, then we can move to developing a plan. And what are the features of a good plan? Much before Lisa, many years back, I analyzed in 27 European countries the cancer plans, and subsequently for the Lancet Pediatric Cancer Commission, which I'm co-chairing with Carlos Galindo with support of UICC, we've looked at all the cancer plans. Two key messages. One, many of the plans are not actually plans. They're just documents. And secondly, very few get implemented. But looking across those who were reasonable plans, and UK and the French plans were actually, I would call them excellent. Then plan from Ontario, which Mary was involved with, is also excellent. There are a number of important features. The first is that these plans articulate a clear narrative. They identify the challenge and the opportunity. Secondly, they provide analysis, analyzing cancer delivery, but also performance of the health system. So they provide an analysis of the state of cancer control. Thirdly, based on these, they identify priorities and the rationale for these priorities. Fourth, they identify clear actions to achieve these priorities and to generate value. And the value can be defined in different ways, in terms of improving efficiency, in terms of improving outcomes, but also enhancing equity and responsiveness to the needs of people. Fifth, they have a clear time frame for achieving these priorities with key performance indicators, with appropriate monitoring and evaluation systems that are geared towards measuring these indicators, with appropriate baselines. Sixth, they identify institutional responsibilities and who is accountable. Many plans did not, very few mentioned implementation or provided details. But when they did, they didn't identify who was responsible or who was accountable. Well, one can be certain that this plan is not going to be implemented because no one is responsible and no one is accountable for implementing it. So it's critical that institutional responsibilities are identified, as are the accountabilities. And finally, sources of new and additional funding are identified to ensure this plan is brought to life and implemented. So as Hong Kong starts the process, and I hope after this meeting, to develop a plan, I've already seen a series of activities to bring all of these under one umbrella to develop a clear plan. These principles can be quite useful. But plan is the beginning, because plans are not self-executing. Somebody needs to take this plan and make it happen. And what we've learned from different reform programs around the world, successful large-scale transformation programs, there are a number of important lessons that can translate national plans or cancer plans into action. And there are 10 important lessons. First is there needs to be visible leadership at all levels. Secondly, there needs to be public awareness, engagement, and support for these plans. The plans need to be their plans. Third, there needs to be appropriate legislative and normative frameworks in place to ensure that plans can be implemented. Fourth, there needs to be evidence with analysis to drive policy. Fifth, there needs to be a transformation team, dedicated team to implement this plan. Six, and very importantly, most plans talked about cancer as a separate vertical program. Cancer needs to be integrated into the health system. And it needs to be part of the health system transformation efforts and part of universal health coverage. Seventh, leveraging technology. Eighth, partnerships, as have been mentioned today. Use all existing assets, public, private, NGOs, foundations. Ninth, research and development innovation to develop scalable models of care. And finally, analytics with monitoring and evaluation for iterative improvement, because cancer is not going away, nor are health systems, and we need to constantly improve to achieve what others are achieving. But I know that Hong Kong has been very successful in many things that Hong Kong has done. And again, in relation to cancer, I'm sure it can be a role model to improve health and well-being of not just people in Hong Kong, but also a role model for the region. And I think the region is looking for leadership. And Hong Kong has this opportunity. So take it. Thank you.